Committee room.
Meeting open to the public. Advise everybody, so the committee meeting is now going to be recorded and broadcast throughout Parliament buildings and online. Public gallery, people are free to use Wi-Fi and use devices as long as they're muted. No photographs or recordings are permitted of the meeting. Apologies? No apologies? None? Okay, Chair's business, just one thing, a couple of things, sorry. The Mark Taylor meeting, we had an informal meeting with Mark Taylor. It was scheduled for this week. It's been cancelled and will be arranged in due course. Second thing, and much more importantly, the Muckamore Abbey Hospital Inquiry launch was today. I attended. I've just come back from the inquiry launch, so I think it's important. From a committee's point of view, we put in record our thanks to the committee, to Tom Clark and his team for their inquiry and their diligence and their report. It's 700 pages long. There's 106 recommendations. The executive summary is 50 pages, so it's an extensive piece of work. It'll take a long time. It'll take a time for us to go through it in detail, for members to go through it in detail. But I mean, it clearly represents an important moment for the patients and families who have campaigned for years to uncover the truth of what happened at Muckamore Abbey. I mean, it's the abuse that they uncovered, the physical and psychological abuse. I mean, it is hard to comprehend that people within our healthcare could have carried out such abuse, particularly on the most vulnerable that they were there to look after. I mean, in the report it'll detail that abuse, it'll detail the scale of the abuse, but also the medical negligence, where patients were not dressed properly, were not fed properly, were over-medicated or under-medicated. I mean, it is just so stark in its findings and so hard to believe. So above all, I think today our thoughts are with those who suffered and with their families, who have obviously shown extraordinary courage and determination throughout this process. They have never let this lie. They deserve answers. Hopefully today produces the answers and the accountability and the assurance that they need that this will never happen again. I understand the Belfast Trust will be making some public commentary on it today at 2:30. The Minister is going to do some public commentary on it today as well. Members will have been notified that the Minister is making a public statement to the Assembly on Monday, so that will allow us to hear from the Minister just exactly how the Department intends to proceed with this report. From our view, I think we'd like to see all the recommendations implemented. Certainly there's going to be a bit of work for us now with regard to the Adult Protection Bill. Just to inform members, I spoke to the chair of the inquiry today and have asked him and his team to come and brief us, and they've agreed to do that. We're hopefully scheduling a briefing with the Belfast Trust and the Minister on this subject, and we hope to be able to schedule the briefing from the Muckamore Inquiry team in advance of that. So I think that will set out, because there were things in the report, there are recommendations that are key to the Adult Protection Bill. There's also stuff around the CCTV. There's the call again for the Duty of Candour Bill to be implemented, so we need to see that. So there's an awful lot of that work for the committee, but ultimately it's all about how we work with everybody else to ensure that patients, particularly those who are the most vulnerable, are cared for in the way that they should be in our health and care system. Dan?
No, just to concur with everything you've said, I think it's an appalling situation where the most vulnerable, the most complex, those who are non-verbal, who cannot speak for themselves, were abused. And I listened very carefully to the chair of the inquiry, and that abuse, as you say, ranged from physical to neglect to inappropriate care to financial and sexual abuse. It is actually just appalling. This is just two things that I want to raise that I think are relevant for the committee. I do think that there is still an issue in our health service of accountability. So the chairman setting out his report talked about systemic failures in management, etc., etc. And there are prosecutions, criminal prosecutions, and we can't obviously talk anything about those. But I do trust that the Belfast Trust starts to set out how accountability is going to be measured in relation to this actual scandal. And I think that is important. I think it's also important that the chair very clearly said that a statutory, and I wrote down his words, a statutory duty of candour should be imposed across the whole system, that politicians should accelerate that and legislate for it. And I know that many of us in this committee are in agreement with that. I don't think that that's a startling revelation in this committee, but I think that that's a validation for us to get on ahead and get that work done. And then I think we need to, maybe not now, but at another date, talk about how we take forward what the chair said in relation to those tests and around investigations. Because his words were that in the Adult Protection Bill it's too complicated. It would ensure that there were no investigations actually, and we need to look at how to amend that bill to ensure that that is appropriately done. Obviously it'll take a long time to go through the recommendations, but I think that today is a step forward, and I hope that the families feel that they've been seen and heard.
I mean, I noted that down during the launch as well, where the chair talked about prosecuting an organisation for what the individual was doing, and he did say that under the current Adult Protection Bill he felt that it was too complex to do.
Yes.
And he is actually offering within the report a simpler way of doing it. So I mean, I do think we will have to look very carefully at that. And I mean, our decision to pause the process of the bill, I think, was absolutely the right thing to do. Yes, go ahead, Colin.
Chair, I agree with all the remarks made so far about the cruelty and inhumane treatment that was given to those patients when they should have been cared for. But just I think an element that we need to investigate, and I hope we can interrogate it here in a grown-up way. We have an awful thing here within our political system of absenting a lot of the responsibility down to arm's length bodies and officials. But there should have been political oversight as well. And I know this goes back to a time whenever my party was in the executive as well, so I'm not doing this as an attack at others. But if this was England, Scotland or Wales, I think we'd be looking at a health minister getting ready to resign over something like this coming to light. But here we go straight away to say where was the accountability of officials. And whilst officials may not have done exactly everything that they should have done either, accountability starts at the top. And we have a minister that is responsible to an executive that's responsible to this assembly. So I hope that we as a committee can take that on board to work out how does that accountability start at the top. And I have no doubt that there being no assembly here for many, many years, and the disconnect that there was gave a space where people felt that there was no accountability. So I hope that we can work that through as well.
So Danny, go ahead.
I'm just to agree with everything else that's been said, but I think it does lend more again into the question of the culture within the Belfast Trust. We've had scandal after scandal within that particular trust. I think it's something that we have to maybe look at as a committee in the round. I think it also shows the power of a public inquiry, that to actually get results you do have to have a public inquiry, you do have to pull in the people who were there at the time in order to give answers. And we know recently the Ladies with Letters were denied a public inquiry by the Minister, and I think we should maybe be looking at that as a level of accountability that should exist for these scandals.
Yeah, I mean, on the Belfast Trust thing, because I had the opportunity to speak to some of the families, and they had read bits of the report that I hadn't read at that time, that they were extremely concerned about the attitude of the Belfast Trust during the inquiry with regard to the chair, about what they were accepting and all the rest of it. Now, I hope that the new leadership, both at board level and chief executive, will mean that attitude is no longer the pervasive attitude, because I mean, I would think it would be very foolish of any health trust with this report to do anything other than fulsomely accept their part in it, their responsibility for it, and the recommendations that come with it. Okay, everybody content to move on?
Yep.
Okay. Just draft minutes. Can I refer members to the draft minutes of the meeting held on the 11th of June? Are people content? Yep. Matters arising? None? Okay. So, item number 5, SL1, Public Health Notifiable Diseases, Hantavirus order, and also item 6, we're taking 5 and 6 together. So, SL1, the provision of health services to persons not ordinarily resident, regulations, NI 2026. So, the committee is going to take evidence now from officials on both of these SLs as they relate to hantavirus. So, I welcome Christine Henderson, who's Head of Communicable Diseases Policy, Dr. Louise McCorry, Senior Medical Officer for Health Protection and Communicable Diseases, and Noel Griffin, Head of Healthcare and EU Citizens' Rights Branch. So, these are all very welcome. Can I refer members to our papers at page 24, and we have a clerk's memo, the SL1 papers. And I'm now just going to hand over to yourselves for opening remarks, and then we'll take any questions if there is.
Okay, thank you for the opportunity to attend the Health Committee this afternoon to present the 2 SRs the Department is proposing. My name is Christine Henderson, I'm Head of Communicable Disease Policy, and we've got Dr. Louise McCrory, Senior Medical Officer for Health Protection and Communicable Diseases, and Noel Griffin, Head of Adult Palliative Care, Access to Healthcare and EU Citizens' Rights. The Department of Health is proposing to make 2 statutory rules. The first is to make hantavirus disease, including hantavirus pulmonary, cardiopulmonary syndrome and hemorrhagic fever with renal syndrome, a notifiable disease under the 1967 Public Health Act. This will require medical practitioners to share patient information with the Public Health Agency if they become aware or have reasonable grounds for suspecting that a person they are attending has hantavirus. And the second is a consequential amendment to the provision of health services to persons not ordinarily resident, Regulations 2015, more commonly referred to as the PNOR regulations, to include hantavirus diseases in the list of conditions which are exempt for charge for treatment. Making a disease notifiable supports a timely public health and HSC response, including access to specialist infectious disease services when required, enables surveillance and monitoring of disease activity to reduce onward transmission. It also ensures enhanced patient care and financial support, particularly where a patient is required to self-isolate or suffers financial hardship. Schedule 1 of the Public Health Act provides a list of notifiable diseases, and the Department can add and remove diseases from the list by means of an order subject to negative resolution. The power to amend this list has been exercised a number of times in recent years due to coronavirus and hepatitis C and Mpox. The inclusion of hantavirus on the list of notifiable diseases recognises the seriousness of the recent outbreak and will provide the necessary legislative framework to protect public health. As demonstrated by the outbreak on the ship, there were 3 of the 4 UK nations and the ROI were affected by having contacts. We need to recognise that it is plausible that an HCID strain of hantavirus could become a public health issue in Northern Ireland. Access to publicly funded healthcare in Northern Ireland is based on ordinary residency. Anybody who is not ordinarily resident is a visitor, and access to healthcare in Northern Ireland is provided to visitors under the PNR regulations. These regulations make certain health services available to visitors in Northern Ireland at a charge determined by the Department of Health. The regulations also provide various exemptions from charge. Some services are always exempt from charge, while some categories of visitor are exempt from charge. Schedule 1 of the PNR regulation lists diseases for which hospital treatment is exempt from charge for visitors to Northern Ireland. This list has been also amended in recent years in line with the changes to Schedule 1 of the 67 Public Health Act. That concludes our opening remarks, and would like to invite any questions.
I literally just have one question. So we had requested views from the public via our methods and got none. Is there any negative views out there in relation to this?
Because of the need to make it an emergency, we didn't consult on it. We considered a technical amendment. So, given the risk to public health if we were to get it, I think that
supersedes everything.
yeah.
Okay, fair enough. I have no other questions. Do members, Dan?
Just one question, so it was just maybe out of interest really. I've no issue with the proposal as such. I mean, this was supposed to be something, if I remember rightly, that was communicated via vermin, South America, and spread in the ship. What are the dangers of this in Northern Ireland, apart from somebody coming in with it? Or is that the main danger?
That is the main danger, so it is, yeah.
Okay.
Yeah, so it's not something we have in the environment in Northern Ireland, so it would be a communicable disease that we would get through people travelling.
Yeah. Okay. Thank you.
Annie?
Thank you. Yeah, they were obviously going through this quite quickly. So is this purely a precautionary measure? Is there any need for such urgency in this? And what would be the risks to the public if we just went through the normal procedure?
It's a really good question. I mean, I think the reason for making the amendment at this stage was because of the concurrent outbreak that was happening on the cruise ship, and the fact that the incubation period was so long and there were so many countries involved within the cruise ship, but also the fact that a lot of the nations within UK and ROI had cases and contacts, and so for that reason we felt that it was prudent to be able to do something more urgent than wait, given it's a high consequence infectious disease, so easily spread between people. Allowing us to have that enhanced response was something we felt that we would need to have more urgently than not.
And the ROI and England had made it notifiable, so we wanted to maintain parity with them.
Underline.
And you're not aware of any particular cases in Northern Ireland? Or the potential for that?
Not at this moment.
Not at this moment. But there is a long incubation period?
Yeah.
8 weeks?
8 weeks.
So somebody may have it at the minute and not know.
We've not been made aware, but I mean that's something that.
Thank you.
Okay, thank you very much. Thank you. So, members, committee agreed to schedule consideration of the policy to intention of the proposed rule today's meeting based on the request from the Minister for an expedient time frame. So the purpose of the proposed SRs, as we've heard, to make hantavirus disease a notifiable condition under the Public Health Act and subsequently remove charges for any visitor for treatment in relation to hantavirus, and the proposed SR will be subject to negative resolution procedures. So, as I said there's no responses to our call for views and proposed rules as yet. The calls for views remain open and any further responses will be shared with members at SR stage. So can I ask members if you're content with the proposal for the statutory rule, the Public Health Notifiable Disease Hantavirus Order NI 26? If you're content also with the proposal for the statutory rule provision of health services of persons not ordinarily resident, regulations NI 26. Content? Okay, thank you. Thank you very much. Okay, similarly, members, we're going to take items 7 and 8 together. They're both combined. So 7 is the SL1 Tobacco Retailer Fixed Penalty Amount Amendment Regulations 2026. And item number 8 in our CLAR is SL1, the Tobacco Retailer Miscellaneous Amendments Regulations NI 2026. So committee is going to take evidence from officials on both of these SL1s as they relate to the retail of tobacco and vapes. So, just wait till we get the officials. Hopefully they're there. Or maybe going too quick. That will be a first.
Are we doing the wrong?
Okay, can I welcome Leslie Heaney, Head of Tobacco Control, and Sean Garland, who's the Deputy Principal Tobacco Control. So members, just to let you know, papers are at page 45 to 58 and also page 64 to 75 in our main pack. That includes the clerk's memo for each SL1 and also the department's SL1 paper. So going to invite yourselves just to make any opening remarks and then we'll take questions if we have any.
Thank you, Chair. So thanks for the opportunity to brief the committee today on these regulations. Before moving on to the statutory rules, I just thought it would be helpful to set out some very brief background. Smoking remains the leading preventable cause of death, disability and ill health. In Northern Ireland, it is responsible for over 2,000 deaths each year, with over 25,000 smoking attributable hospital admissions annually. In 2019-20, Northern Ireland's hospitals spent £218 million treating smoking-related conditions. It is also important to consider the impacts associated with vaping. Recent research conducted by the Public Health Agency examined the views and experiences of young people in Northern Ireland aged 11 to 18 years old in relation to vape and e-cigarette use. The findings showed that 20% of respondents have tried a vape at least once, and 15% are current vape users. In Year 14, that's 17 to 18-year-olds, 46% of Year 14 pupils currently vape, and 53% of all respondents who indicated that they currently vape are regular users, of which 65% indicated that they vape daily. The committee will be aware that the Tobacco and Vapes Act, which has the support of the Northern Ireland Assembly through an LCM in February 2025, was enacted on the 29th of April this year. This historic piece of legislation represents a landmark step forward in saving lives and protecting future generations from the harms associated with tobacco use and nicotine addiction. The UK Tobacco and Vapes Act introduces a range of important measures, including making it an offence to sell tobacco products to anyone born on or after the 1st of January 2009, and that commences on the 1st of January 2027. Banning the sale of non-nicotine vapes and nicotine products to under 18s, banning the free distribution and discount of products, extending the tobacco vending machine ban to also include cigarette papers, vapes and other nicotine products, strengthening enforcement activity to support implementation of the measures, extending the existing tobacco retailer register to retailers of vaping and other nicotine products, and finally powers to introduce retail licensing in the longer term following public consultation. The immediate focus of the Department is to support the implementation of the key provisions within the Tobacco and Vapes Act, including the development of necessary secondary legislation. The two statutory rules before the committee today are technical and consequential to the provisions contained within the Tobacco and Vapes Act. Firstly, the Tobacco Retailer Fixed Penalty Amount Amendment Regulations. These regulations will revise the list of fixed penalty offences and prescribe the relevant penalty amounts to reflect the new and amended offences introduced by the Tobacco and Vapes Act. They will also revoke the Tobacco Retailer Fixed Penalty General Amendment Regulations Northern Ireland 2021, as their provisions are superseded by the amendments introduced through this statutory rule. Secondly, the Tobacco Retailer Miscellaneous Amendments Regulation 2026. These regulations make a number of administrative changes to secondary legislation, which include updating the information required for registration applications and revising the prescribed wording of the Restricted Premises Order notice to ensure that the requirements apply to tobacco products, herbal smoking products, vaping products, nicotine products and cigarette papers. Also updating the return postal address and email address for details for the retail register to reflect the updated contact details of the newly extended register. And finally, amending the form of fixed penalty notice by removing obsolete statutory references and updating payment methods to include electronic and online payment. The purpose of both of these statutory rules is to ensure that the legislative and enforcement framework in Northern Ireland is fully aligned with the expanded regulatory framework for tobacco, vaping and nicotine products introduced by the Tobacco and Vapes Act 2026. As noted, the statutory rules are technical in nature. They do not introduce any new policy and have no additional cost implications for the Department of Health in Northern Ireland. In terms of timing, the regulations will be commenced on a phased basis to align with the corresponding provisions in the Tobacco and Vapes Act. That is, the 29th of October 2026 will see the commencement of provisions relating to age of sale, proxy purchase of vaping and nicotine products, extension of the vending machine ban and restrictions in free distribution. The 1st of January 2027 sees the commencement of the tobacco age of sale provisions. And finally, the 1st of March 2027, the provisions relating to the extended registration requirements for retailers of tobacco, vape and nicotine products become enforceable, with fixed penalty notices being issued. So in summary, these regulations will support the effective implementation of the provisions in the Tobacco and Vapes Act to ensure that they operate as intended in Northern Ireland. Sean and myself are happy to answer any questions you might have.
Okay, thank you. 2,000 deaths as a result of cigarette smoking still shocks me, to be honest with you. Speaking as a reformed smoker, I say that because given that I don't smoke anymore, and I rarely am in contact with people who smoke, but it's obviously something that policy needs to be directed towards from a public health point of view. So no issue with that. Support all that you're doing. But in terms of this particular SL, you're saying there was no consultation because the amendments are technical and non-consequential or in nature, but it will have an impact for retailers here. So I mean, I'm not sure why there wasn't consultation allowed with the retail sector.
Well, I can take that question. Yes, there was no formal public consultation carried out, but we have engaged with retailers. We have met with regard to the Tobacco and Vapes Act with a number of retail organisations in Northern Ireland, including Retail NI. It's anticipated that there might be some small cost to retailers in terms of training staff, but we consider that would be a one-off cost. We have actually developed on a Four Nations basis some guidance documents, there's 4 sets of guidance: smoke-free generation, vaping and nicotine products, vending machines and fixed penalty notices. Those guidance documents were shared with a wide range of business and retail organisations in Northern Ireland in draft form to seek their input and raise any queries as part of the development of the guidance documents. And we will be continuing. We have just actually recently emailed out to retail organisations again to offer to meet with them and to update them further.
Okay, fair enough. Secondly then, just because local councils are going to be expected to enforce the new laws, and are you content that they have the resources to do it? Because I mean, there's no point in having laws if they're not enforced.
Yes, we have set up a joint implementation group, which is chaired by the Chief Environmental Health Officer in the Department of Health. That group has representation from the Council Tobacco Control Officers, also the Consumer Protection Officers within councils, as well as the Department and the Public Health Agency. The reason for that is the Public Health Agency fund the 12 tobacco control officers across Northern Ireland who are based within local councils, but they're funded through the PHA as part of the tobacco control strategy. So that joint implementation group has been meeting every 6 weeks. And in fact, just this morning, I was at an engagement event with tobacco control officers from the councils to brief them on the provisions which are commencing in October.
Okay, thank you. Lando, are you looking on this?
Sorry, Chair. It's actually just been answered. My concern was how the councils would do it, but that answer has answered that. Thank you.
Danny?
Thank you, Chair. Yeah, just discussing this with some young people, and I know we had the Northern Ireland Youth Assembly who were very, very helpful during our investigations around this bill last year or the year before. But talking to some young people recently, they've noted a rise in snus and tobacco pouches. You mentioned other nicotine products quite a few times there. Would that include snus and these tobacco pouches as well?
Yes, it would. Now, snus is actually, although a lot of the young people call the nicotine pouches snus, it's actually an oral tobacco product which is actually banned in the UK. But nicotine pouches can currently be purchased by under 18s, but they are within the scope of the Tobacco and Vapes Act. So as of the 29th of October, it will be illegal to sell those products to under 18s, and also proxy purchasing, so buying on behalf of somebody under 18 will also be prohibited.
Yeah. In terms of advertising and marketing of them?
So advertising and marketing are Secretary of State regulations. So the Secretary of State has the power to make regulations in relation to advertising and marketing. And the Secretary of State announced that those will commence on the 1st of June next year.
That's right.
So those are UK-wide by the Secretary of State on behalf of the whole of the UK. So that'll extend the existing tobacco regulations to cover vapes and other nicotine products within the scope of the Act.
We'll include all those products as well.
Mm-hmm.
Okay. That was my question. Yeah. Thank you. Thanks, Joe.
Okay, thank you very much.
Thank you.
Happy with that. Okay, members, so the SR is in relation to penalties, as we've heard. It's going to be subject to draft affirmative procedure. It will be scheduled for plenary debate. The other proposed SR will be subject to a negative resolution procedure. So there's no responses that we have received to our call for evidence or views on the proposed rules. So we had previously agreed to consider the policy intention of these SLs at next week's meeting, 25th of June. However, if members are content with the information we've received, we can make a decision today. So I'm going to ask if we are content with the proposal for the statutory rule on tobacco retailer fixed penalty amount amendment regulations, NI 2026. Content?
Content.
Thank you. And then also if we're content with the proposal for the statutory rule, the tobacco retailer miscellaneous amendments regulation, NI 2026. Content? Thank you. Okay, members, moving on then to item number 9, which is an oral briefing from Mesh Ireland. Can I refer everybody to page 80 of the main pack and a printout which is on our bench in front of us as well. That's also included in the table papers, but we have it in front of us. These are papers relating to Mesh Ireland, so I'm going to welcome Mary. She comes. So can I just welcome Mary McLaughlin, campaigner, to the committee. So Mary, you're very welcome. We've got your papers and all of that in front of us and we've read them. But if you want to give any opening introductory remarks, that would be great. And then we will take questions from members.
Okay, first thank you to the Chair and to all the committee members for the opportunity to brief you today on behalf of all the women impacted negatively by mesh implants. My name is Mary McLaughlin. I'm the founder of the Mesh Ireland campaign with the motto "For Mesh Injured, by Mesh Injured." The campaign is now a decade old. The public healthcare system adopted mesh implants 3 decades ago. Our mesh women are ordinary women. Many are now older people. They did nothing wrong. They are not to blame. They trusted our local healthcare system. They presented with a common complaint of pelvic organ prolapse, often related to childbearing years. The main symptom is bladder incontinence. They trusted the system. Their GPs referred them to our hospitals. The urogynecologists used plastic mesh implants to stop the incontinence. Patients believed in their doctors when told that this quick fix 20-minute procedure was safe. Many patients remained unaware of the serious and not uncommon risks of such surgeries. It is a scandal. To be clear, the health problems of a mesh-injured woman are deeply rooted in unmerited claims by the public healthcare system. The operation relies on the implant being coated with a chemical substance which accelerates the vaginal tissues growing through the mesh grid and over the entire surface to encase the implant in scar tissue, which then holds the mesh implant in place. It relies on the surgeon putting the implant in where it should be and being honest when mistakes have been made. It relies on the mesh never finding its way beyond the scar tissue encasement. It also relies on this accelerated inflammatory response to stop, as the mesh implant is a foreign body made of polypropylene plastic. A prolonged inflammatory response would mean that as long as the implant is in the body keeps fighting the foreign body. This is recognised as the cause of autoimmune conditions and years of long and repeated bladder infections. As the devices are implanted into the female pelvis, and some in the inner thigh area, the function of voiding organs is impacted by this operation, as is the reproductive and sexual organs, neurological function as related to possible nerve damage, and dysfunction of the signals to the brain to void, the function of walking, standing and sitting. The mesh injured community suffer from a combination of some or all of the things that can go wrong. Exposed mesh which has been misplaced into organs such as the bladder pipe and the urethra, it is sharp and causes inflammation. Urine stones gather in the mesh grid, causing bladder stones. Constant bladder infections persist. The everyday, women wake from a poor night's sleep, often with opiates in their system and long-term antibiotics. Each visit to the toilet is painful due to infection, erosion, and retention. Some women cannot control their voiding functions. The painful toilet routines are followed by stripping beds. Some of the women are permanently catheterized. With every step, the mesh pulls the legs, the pelvis, the vagina. They develop autoimmune diseases such as fibromyalgia. Cases of cancer have also been noted in medical documentation, and I am aware of one member in our group who died in 2018 as a result of squamous cell carcinoma in the bladder, which remained undetected for a while, and by the time it was detected, it spread. She survived a few years, having had most of her pelvic organs removed, and she died in January 2018. It follows that our once vibrant women's lives have fallen apart. They've lost their jobs, their pension accruements. Some have lost their marriages or the hope of ever having another relationship, and the planned financial dependencies which a couple build upon for their future. They have lost their voices because of the deep indignity and shame they associate with their symptoms. They have lost normal social interactions. They are isolated. Their mesh injured-based claims for personal independence payments are regularly and systematically rejected because the women can manage these conditions on their own and do not require extra help. They have gaps in their national insurance contributions. Mm-hmm. They have been abandoned to live and to die with these implants in their bodies. The thought of entering old age with mesh injury is chilling. Our public health system was silent on the inability of its surgeons to fully remove these implants when problems arose. By acts or omissions, women have been successfully gaslighted. The cause of their symptoms regularly denied or trivialised. The request to be referred to super specialist surgical skills denied. I walk side by side with all those women, but where are you, our politicians? Devolved administrations such as Scotland have led the way through inquiries, legislative reform and redress in terms of access to the global surgical super specialist, reimbursement of patients who have funded their surgeries privately, and a small interim payment of £1,000 per patient, whilst Westminster considers the possibility at some time of compensation schemes. My message today is that there has to be a redress scheme, put in place before this Assembly mandate expires. I have campaigned for 10 years. We are all aware of the forthcoming elections and the time it takes to set up committees and parliaments, and I don't believe that the information will change substantively. And therefore, this is my appeal to people like yourselves who have supported me over the years to step up and move swiftly. Empty promises won't get us anywhere. The Northern Ireland Assembly are aware, or ought to be aware, that the Belfast Mesh services have failed the women. I have informed and written on multiple occasions in the past 10 years. If my word is insufficient, I would direct to a damning evaluation of what our local mesh injured women can expect, as provided in the 2025 Department of Health publication, Getting It Right First Time, Northern Ireland Efficiency Programme report. It states, urogynecology patients, incontinence and/or prolapse have fared particularly poor across the entire province, but in particular at the regional mesh centre in Belfast City Hospital. These conditions have a low priority, with many patients waiting for many years for a consultation and then significantly longer for surgical intervention. These are often older patients suffering from a debilitating condition and very often in silence. There is no immediate prospect for change without an increased size of workforce as well as immediate appropriate surgical access. In brief, in my opinion, and in the opinion of our women, there has been unconscionable foot dragging by authorities. The mesh injured women have effectively been left abandoned. Attitudes, inaction and indifference have characterised official responses. Those at the top of our health service do not appear to care or to care enough. There is a crying need for you, politicians in general, to stand up for the women who have been so badly and to do so now. Only you can effect changes in official attitudes. Only you can direct funding. Only you can stop this scandal, and it is a scandal. It has been recognised worldwide as a scandal. Only you can demand action to end this nightmare for the mesh victims. On a personal note, I have been fighting for a decade to get a positive outcome for the mesh injured. I've represented Northern Ireland at the Coverage Review. I have travelled to Scotland and worked with the Scottish campaign to get the women to Dr. Veronica's in America. And I have helped on a personal level many, many women who phone me and talk to me, and I help them where I can. I continued to suffer myself from the damage of mesh implants. I've had a good surgery in America in 2019. I've been restored to my workplace. I've built up a full-time job since then. I have pains and aches and pains, but I can live with them, and my life is more fulfilled. I'm at the end of my effort in terms of campaigning and coming and speaking individually to politicians. I have a wealth of knowledge, but I don't know what more I can say. I'm at the end of my effort. I don't think I can do any more. So for now, my proactive campaigning days are over, but I remain available to anybody who wants to speak to me about mesh. Having outlined the background of mesh injury and the situation of the injured, I would welcome a progression of the discussion today to how you, our elected representatives, can take swift action to enable our women to get the medical treatment they deserve without undue delay, and not to hope monger when no hope is in sight. Thank you.
Okay, Mary, can I just first of all pay tribute to you for the work that you have done over the last 10 years in terms of fighting on this issue and raising this issue and pushing politicians on this issue. You described it as a scandal. I don't think anybody could disagree with that. It's just another I suppose, a horrific example of the way women are treated within our health service here, or in some cases not treated within our health service. So, I mean, your evidence has been shocking on a day when, you know, all we seem to hear is shocking evidence. So I appreciate you coming before the committee. I have had a couple of constituents who have been affected by this, who have come to me seeking help. I have to say the help and assistance of my party colleague Arlea Flynn has always been called upon in terms of pushing this issue. So I'm actually going to defer to Arlea to questions now.
Yep, thank you, Chair. Thank you, Mary, for coming along today. And look, I know, because I've had the pleasure of obviously campaigning alongside you since 2017, so 9 years, coming up to 10 years. It's really scary even when you say that out loud. But I know that you've been over to Westminster. I know that you've been down in the Dáil in the Health Committee in the South, and I know you would talk to anyone who's going to listen to you on behalf of the women that you're obviously working with, and you've been affected by this issue yourself. And I do share your frustration. It's actually a bit embarrassing, I think, that we're 10 years on, and really when you look at what has moved on in terms of the services for the women, and I do worry about this. I think that, you know, all the meetings have taken place over the years, and we've done all that. Getting the implants, I suppose, banned, getting that initial pause on the mesh implants was the big victory, and that was a victory, because when we first met, they were actually still being implanted regularly into women's bodies, which is a disgrace, given that there wasn't even proper, as we know, there wasn't proper tests in terms of, or trials done in terms of the impact this would have on a woman's body. And then the most shocking thing is that our healthcare system, not just us, because it's a global issue, but we're putting these implants into women's bodies and not knowing how to take them out. And that, I mean, when you say scandal, it is an absolute scandal. It's a disgrace. So Julia Cumberleach was 2020, so 6 years ago, coming up to 7 years, and I know obviously some of the recommendations coming out of that where they were calling for the redress, which is important. But I just want to ask you two questions, because I'm sure others will have plenty of questions for you. But the big thing for me is, see on the removals, right? Up until a couple of weeks ago, I put questions into our health minister to ask him to confirm, right? Because the ban was put in place on the mesh, so we're no longer putting them in. And then then the mesh clinic was set up in Belfast to say that removals could be done. And only a number of weeks ago, I had asked the question again: can our health system, can our health service, does it hold the expertise to fully remove the mesh implants? And one answer was telling me that wasn't the case for more complex cases. They would do ECRs and they would refer patients over to Britain. And then when I done a follow-up question, I was then told that yes, the full removals can be done on complex mesh removals. So I am still 10 years on. I am still confused, and I still feel that I can't get a straight answer in terms of these mesh implants that have been put into women's bodies. Do we have the expertise to fully remove them? And if we don't, I think we need to be open and honest about that and say, right, so how are these women getting these devices taken out of their bodies if that is their wish, particularly if they're causing them harm? So I'm frustrated by it, and I understand your frustration, and so if you can give me your assessment, the women that you're working with, can our system do full mesh removals?
No. I'll try to expand on that. I was the first woman in Northern Ireland to be sent to London to have my mesh fully removed in UCLH by the team under Professor Suhair O'Neill. If we fast forward to today, the same surgeon has been in front of the GMC several times and has had her suspension extended several times, And at the core of this issue was that she was not removing the mesh fully. She was leaving substantial pieces of the mesh in the women's bodies and telling them they had been removed fully. Luckily, I went on radio and said it was like getting a golden ticket to go to the surgeon. I was elated and I told women how to do it, and I think there was something around 20 ECRs that were made outside of Northern Ireland, but they've stopped giving the ECRs on the basis that they can do these removals. And then I realised that I was being sold a pup by the London team, and I arranged for my surgery in America. I told nobody I was going. I travelled with 2 other women, one from Larne and one from the south. We told nobody we were in America because there was such a backlash if anybody said anything against this surgeon. And of course the women in Northern Ireland who continue to go from with the ECRs, they ended up with partial removals. And the Trust did not contact any of us to say, you know, this situation has happened, we're referring these women elsewhere to now try and get the remainder mesh out. So that is something that has happened over the years. There was a surgical backlash from the surgical community in the UK about Dr. Veronicus and his super specialist skills. And without going into which doctor where, it is now, I read medical journals, I now read that the medical communities in the UK are publishing that they may have underestimated just how difficult these mesh removal surgeons are. And a lady in our group was kind enough, she did a few FOIs, I've got a few in. On average from 2020 to 2025, I think the average was, Nottingham Hospital was able to tell us that they on average have been able to perform 2 full removals of these transobturator meshes, and I've sent some background details. Southampton on average 2, Cambridge on average 2. I forget, I haven't got the Oxford sheets with me, but I do remember that they are now starting also to laser the mesh away. Now, given that that is plastic, I have 2 issues with that. First, do they think the plastic goes up disappears? It's going to end up somehow in your blood system and everything. It reminds me of the Morcelliter scandal years ago when they cut up stuff to suction it out and all the cancer spread then in the patient's bodies. It just reminds me of that. And all mesh removal is complex mesh removal because it is embedded, and it requires microsurgery. Now, when we get responses back from the Belfast Mesh Centre, and we've done this together over the years, one of the things that annoys me is that the Belfast Mesh Centre's responses rely on, we're not able to tell you the exact figures because it could identify patients. Yet UK-wide, the hospitals are sending back stats. So they've always done it between 0 and 5 or under 5 or over 10. And there's one year where there's a statistic of 6 that I know of, but not through the FOIs, but because I know Professor Hashim from Bristol came over to Northern Ireland, and I was in touch with Professor Hashim that weekend, and from my best recollection is they performed six mesh removals when he was on site at the weekend. You cannot train to remove mesh. You cannot train to remove mesh in a weekend or by watching a video or something. It's unheard of. Surgeries in general, surgeons, consultants, so we're talking about urogynecologists and their specialists. The super specialism is a urogynecologist who can remove these implants totally. That is a super specialism. Nobody in the UK is claiming that super specialism. In recent documentation that I've read, there is this acknowledgement that they perhaps thought in 2020 when Cumberledge was published that they could upskill quickly. Mm-hmm. But from the information I've sent you, you can see some of these operations take 4.5 hours, 8.5 hours. We, don't have the surgical time. The surgeons don't have the operating time. they don't have the theatre resources, they haven't trained, and 20 surgeries is the standard default per year for any surgeon performing a particular skill and keeping the content of the skills the standard. You can't do one year and then 2 years later and claim that you're an expert in anything. That's not controversial. These are in the medical community's own guidelines of frequency. And who is training these surgeons? Now, the women were implanted on a see one, do one, see one, teach one, do one. So my feeling is that our women are a learning curve for surgeons to try and take the mesh out. I can give anecdotal reports from women who have gone in for mesh removal and have woken up and the mesh has not been taken out. And then they get this like, oh, it was very complex. Well, you think after a while, yes, every operation is complex. Look at where they have to go into your body and start taking away scar tissue and nerves and everything. This is why the women can get damaged by partial removal. Very complex. They couldn't find the mesh. They couldn't do this. They couldn't do that. They took a bit out. Women asked for pictures, not very forthcoming with showing the images of what they've removed. I mean, the standard is you take a picture, you put a measuring tape there, you time stamp it that you know it's your implant and not just some picture that you're being given. That doesn't happen. Then they're asked to self-catheterize. Often they have damaged bladders afterwards, catheterize and left at home. Open wounds being dressed by care nurses, and then they have to wait for an appointment at the hospital. They are often palmed off to not their surgeon, somebody else, and then they want to do more tests and more urodynamics. And I have women who for 3 years have been fully incontinent with no date, and some of them have been back twice to get the mesh out and still don't have the mesh out. And they phone me and I say, I don't know, because the problem then is, even if you find a more practiced surgeon in the UK, the women can't afford to pay for surgeries. An awful lot of them can't afford. They're about between 18 and 24,000 pounds, the surgeries. B, when they send their medical notes to a private practice surgeon, they see that the woman has failed twice in mesh removal, so they're litigation on legs, and the surgeon doesn't want to go anywhere near them, and so they're just told, no, I'm sorry, I can't help you, and then they're back to where they started. And now, I did do a Freedom of Information June 2025, so it's a year ago, on just what the Northern Ireland surgeons are logging with the BSUG, which they said they were going to log with. In relation, so I asked them several questions. Since the NHSE commissioning of the mesh centres by the Department of Health in Northern Ireland in March 2020, which is post when the mesh centre was set up, registration has not been operational, so registration of registering their surgery outcomes on the BSUG database. There has been no data entered in the British Society of Urogynecology, BSUG, or British Association of Urological Surgeons, BAUS database, as Belfast Trust await the regional introduction of the mesh in this registry. And I must also say that those registries are on voluntary basis. So obviously, if you have good outcomes, you might be wanting to log them, and if you have bad outcomes, maybe not. So the reliability of that. Adverse incident reports. If you remember way back, we talked about the MHRA and it was AIC Northern Ireland, which has since been disbanded and everything's gone back over to London. The number of adverse incidents reported as a total and a breakdown year number. Originally, Belfast Trust aligned all mesh-related cases to one adverse incident report due to the communality of the clinical cases. So unless every patient is using this yellow card system, then I don't know how many, the communality of the clinical cases isn't reflected when they only submit one report. The yellow card doesn't really work. I did that. I progressed it to the very end. Ultimately, if you have your medical implant sticker on your medical records, and many patients are finding those stickers are missing, you can give the batch number. They trace it to the manufacturer, and they ask the manufacturer, was there any problem with this batch? So they often come back and say, no, there was no problem with this batch. There might be some of the prolapse meshes that use metal tacks in a woman's vagina to tack the big mesh is down. I sent some photos. Sometimes those tacks broke and the mesh coiled up inside the woman, and those are more readily found in the databases. But the MHRA just rubber stamp everything that comes out of America, and so this regulatory regime isn't designed to catch this. It doesn't catch it. What else did I ask? I asked about the multidisciplinary teams. Multidisciplinary teams are just a group of specialists like urogynecologists, urologists, colorectal surgeons, physiotherapists. They are a collection that form an informed group of people who can help review patient files and discuss. They are not super specialists. Multidisciplinary teams exist in every discipline. All patients are discussed in the regional MESH multidisciplinary meeting, and their discussion is recorded in the individual patient's medical records, the Northern Ireland electric car record, and now in digital medical record for each patient. That may be the case, but it may not be the case because many patients can't find any records of what goes on in these MDTs. I asked about the patient information leaflets. We know that to give informed consent, a patient must be given an information leaflet to take home and discuss and look at. I didn't get any. Many women didn't get any. I've asked the Trust for their historical patient information leaflets on these things. I didn't get any response. And the response in the 2025 was Belfast Trust Gynaecological Service used the standard trust preoperative consent process. In addition, a patient is provided with a relevant leaflet pertinent to their clinical condition. Each of these leaflets are agreed and published by BSUG for the NHS. The fact of the matter is, up until and a while after the 2020 Cumberledge report, first do no harm, these information leaflets were not standardised and they were very flimsy, and now they have been updated, that there's much more information given. However, given there is a pause on mesh implantation, it is good to know they've been updated, but it is a little too late. And there have been no mesh slings known as TVT, TVTO taught implanted by the Belfast Trust from the 11th of July 2018. So you can see that you can talk up having an MDT and all these services. The women's experience is they're sent on repeat hamster wheel of diagnostics, coming back every half year, every 3/4 of a year. Orlia supported us with getting the translabial scans into the Trust. We were told by the London surgeon that we needed these scans, and now hindsight's a wonderful thing. It is useful for women who have had a partial removal, that they can think they have had a full removal, that they can go and see. They can go and see whether all the mesh is taken out or just a little bit. In some cases, women have only had 2 or 3 centimetres taken out of a 28, 30 centimetre long implant. And then when they came back to their doctors and said, I'm in pain, the doctor said, well, it must be in your head, it must be psychosomatic, because the implant has been taken out. So the GP see the records and it says it's been removed. And the women are walking around. How often do I get calls from women, particularly in early days, crying down the phone when I say, no, I have the same thing as you, and they just cry because they thought they were a unicorn and they were getting sent to psychologists. And then surgeons are not they're not frank, they're not clear, saying it's very complex. I think everybody knows it's a complex surgery, and people who shouldn't do operations that they can't do. They shouldn't deny the patient the right to find a specialist. They should say, I can't do this, but I know there is a surgeon elsewhere. I tried in the south, because I thought of north-south things, that maybe the women could go to the south initially. I thought maybe there's good surgeons down there. But it's more or less the same story, that women that do go in, a lot of them are left in a very bad condition, and then the surgeon doesn't know what else to do. And, you know, having your bladder removed or your bladder function diverted into an ostomy or something like that starts to be. The women that go to America, we've had over 20 people in our group have gone to America. They've all had all their mesh fully removed. They get pictures, their pictures taken during an operation with timestamps, videos. If the surgeon cannot remove all of it, I know sometimes the mesh is deeply embedded, for example, into the pubic bone, and surgeons can only scrape so far without damaging the nerve system. So if things like that happen and they can't take it out, the surgeon is honest and said, you know, there's a thread or two left in. The argument before was, oh, we don't know whether full removals or partial removals, which is best. We don't know patient outcomes. That's because they don't do enough. They don't do enough to collect any meaningful data. The other thing is we now have the biomedical engineering scientists and autoimmune scientists now publishing, saying that as long as this mesh material is inside the women, their bodies will continue to develop autoimmune diseases. And I saw that some of the lead UK community, they are now sort of trying to think, well, are the women allergic to this or not? It reminds me vaguely of mesothelioma, where we said there was guilty dust that remains in the body, and at some point it triggers. There's always been a large denial of the carcinogenic quality of polypropylene. I've done numerous letters trying to find out what exactly it is that they coat this plastic with to promote this growth. I keep drawing a blank. Nobody seems to know. Okay. The others. Oh, I was going to say something else. I've forgotten. So I've lost track.
No, thank you, Mary.
Just before you go, I just want to caution everybody, let's not individualise and name individual surgeons. I think that's probably a good precaution moving forward. Certainly.
No, and you can move on to other members now, but I just want to say what worries me is that relatively recently, I did hear from one of my constituents about a comment that was made down in the mesh clinic, and it's just going back to that whole attitude. It was, don't believe everything that you see on Facebook, when the questions were asked around full removals, and it just really worried me. I think it set me back a lot of years in terms of where we were and women not being believed. And I think for this committee, if coming out of today, we can get the clarity around if we do hold the expertise to fully remove the implants, so a woman knows if she is being referred on for these surgeries locally that she can get a full safe removal. I just think it's really important that we get that clarity, and if we don't, then we need to look at the Scottish model or the US model.
If I could just intervene, the problem is, who is evaluating the surgical skills? The surgeons themselves. The surgeons have just completed lots of these surgeries. They're not going to say, well, no, we didn't really have the skills. The women aren't interested in that anymore. They just want the government to provide them with the funds that they can decide, if they want to go and have a surgical removal, that they can decide which surgeon to go to. And if they don't, if they're happy with the local things, that's a different thing. But you don't usually ask a patient who has been damaged, and maybe damaged multiple times over, to stay with the same surgeon. Like, nobody does that. So, you know, this thing about asking the trust to come back, my problem is the delay again. I mean, I think 10 years delay needs some more, something different. There's no transparency.
Okay, Linda.
Thank you, Chair, and thank you to Mary. I mean, the last line that Mary just said about, you know, that issue of you don't continuously go back to a surgeon who would do that. Well, women, because we have no choice.
Yes.
Because we have this exact same circumstance and situation in endometriosis in this place. So this is just constant. It is about women. It is the health scandals around women's services or lack of. And the constant gaslighting of women. Orlea's just alluded to it, not believing them, telling they're lying. This is around all gynecological services. It's around menopause services. It's around endometriosis. It's around the mesh stuff. So for me, you know, there are a couple of things. I mean, Orlea's already highlighted some of the questions that we need to be asking the minister, and we need answers, not waffly letters. We need actual specific answers, given clarity and honesty and transparency, which is exactly, I think Mary's used that word actually quite a bit during her thing. Some transparency, a bit of honesty here from the department about what is or is not available. Because many of these women who have had to have mesh implants have had to have those as a result of previous medical neglect. And that's the truth of it. So this is a constant where women are going to a health service that is injuring them, then injuring them further, then sent them back to the same surgeons to be injured further. And I mean, for me, that is the real concern. So I suppose what we want to find out is the answers to the questions that Orlea has already outlined, but also what is the timeline for the Women's Health Action Plan? Does this form part of the Women's Health Action Plan? Have Mary and those women who she represents been engaged as part of that Women's Health Action Plan? And I mean, those are just some of the questions I would like to see asked of the minister. And I don't want to, I mean, to be fair to Mary, I actually don't have any questions of Mary because I've heard her present before. She's been very clear. She's given us the information. The questions now are to the department, to our trusts, to our healthcare providers, to the surgeons. And I mean, I think if the surgeons know that they do not have the skills, then we should allow them to be honest about that. You know, maybe they've been pushed into a position where they're almost been told, we need to deliver this service, we need to do something, here's what we're going to do for you, what are you going to do for us? And we need to get to the bottom of that. So those are some of the questions that I think that we need to get some answers to. And as I say, I don't believe that any of those questions can be answered by Mary or the women that she represents. They've given us the information. The last point I want to make is that one that Mary highlighted around the number of surgeries that you need to do to actually have the skills. So we are constantly told that in order to have a safe service, you need to have a certain number, particularly around surgeries, but around any specialist service, you need to have a certain number of patients coming through. And I've actually constantly and consistently supported that view. You know, I've where we've had services maybe removed from one hospital and centralised, I've been one of those people who has had sympathy with that and supported it on the basis that if my child or a member of my family was sick, there was something wrong with them and they needed surgery, I want them to get the best, not the closest. In this case, they're being told, we don't need that many patients. We're just gonna do as Mary has said, and probably more eloquently than me, but to me, it looks like a hit and a hope. Let's give it a go, see what happens. But sure, you know, the outcome for us isn't terrible. The outcome for the woman lying on the bed, however, may well be. That's my commentary on this today, Chair. Thank you.
Okay, Linda, and we'll definitely take on board those comments at the finish when we're summing up. Diane?
Yes, thank you, and thank you, Mary. I think your work and your passion for representing women is really outstanding. It is one of those things that we value in this committee.
Thank you.
You also said that you didn't want anyone to hope monger today. That's not a word I actually have really heard much, but I think it's actually very, very appropriate. This committee can ask questions but the person and the department is the minister and the department who need to actually act in relation to it. So I just have a couple of questions, and I recently met a group of men who have real problems with mesh implants in relation to hernia repair. Have you done any work with them, and what do you know the extent of those issues as well? Because, I mean, some of these men were very anxious about coming forward, and they were also, like many women, embarrassed about this as an issue, but very much in pain and really looking a resolution.
Yes, I've done a women's health group on what I knew and what I gained in knowledge, but I have kept an eye on what's going on with the hernia women, or hernia patients, male and female. We have some women on
These
our
were
group.
men that I was
Yes,
speaking
yes.
to.
It might be of interest to you that the Scottish courts have allowed a class action against the hernia mesh manufacturer Covidien very recently, last month. There's been attempts before to take class actions with the hernia mesh, and they weren't put together very well, and the court said we're not dealing with this. But now the argument is, although they're all different products, the commonality of the symptoms are the same. There's a mesh group in the UK, Retropexy Mesh, run by Paula Goss. They're on Facebook. They do all types of mesh, and Paula's had all different types of mesh, so she's very informed. The difference between the hernia mesh and our mesh is that ours is implanted in the pelvis, whereas the hernia mesh is outside, more abdominal. Yeah, so it's a different set of surgeons. There'll be the colorectal surgeons and other groups of surgery. The types of reactions to the material is very common, and these autoimmune. It's the different types of plastic that are used. The problem with removing hernia mesh, I believe, is because they're often very large pieces of mesh, and that the organs have stuck to the mesh underneath, and therefore it is very difficult for surgeons to remove. Again, a lot of the expertise is in the USA, who were ahead of the curve in terms of litigation against mesh manufacturers. Their attorney generals have sued mesh manufacturers for millions, if not billions, of dollars, and created funds to distribute to those injured. So America led with the products. They led with the litigation. They haven't banned it because it's such a big market, and we find that the commercial interests outweigh the patient safety. That's a view held by those injured. But yes, I would agree. I have every sympathy for people with hernia mesh, for any type of mesh, because the problems are the same, and the reluctance to operate is the same. Yeah.
Yes, it struck me as being a very difficult problem for the people who talked to me, and it was quite a difficult meeting as well to do. So just for clarity, I know the chair has warned against naming any surgeons, so we're not going to do any of that. That's fine. We'll obey that warning. Are you saying quite clearly that there are no surgeons with the super skills in Northern Ireland to do mesh removal?
Yes.
Complete mesh removal?
Yes.
Okay, thank you. That's good. Do you have, or where could we go to look for it, any data that compares the Scottish model, where people are being funded to go to other places, compared to outcomes here? Is there any data that we can compare that update of? No. And that's part of the problem, obviously, isn't it? Yeah. And do you know if there are any plans to use international surgeons with these kind of super skills that you describe in the Northern Ireland context, in the way that we brought surgeons from GB in here to do PEG insertions for children? Are there any plans, do you know that, of the department? Because I think these are all questions that we should be asking the department, specifically, have you anyone in Northern Ireland can do this? If you haven't anyone in Northern Ireland can do this, what are your plans to bring someone in that can do it?
If I may give an answer to that, when
Oh,
I
do,
recognised
please.
Dr. Veronica's skills before I even flew out to America, I asked him would he come to Northern Ireland or to the south of Ireland, because I thought women can travel by car on either side, and operate on the women. And I submitted a letter saying, here is a surgeon who can do these skills. I sent it to the Secretary of State, Mr. Pengelly at the time, and to the Taoiseach, I think it was Mr. Harris at the time, in the south. And I said, he is willing to come to Northern Ireland for 6 weeks to operate in our hospitals and clear the backlog. You'd have to contact him directly. My understanding is that he would only be wanting the costs that he would normally occur. And the letter came back from Mr. Pengelly or the Department of Health saying that the CMO was of the opinion that we had these skills locally and therefore he didn't need these surgeries. We tried to bring him to Scotland and I was deeply involved in that campaign. It went on for 2 years. He was meant to come and there was barriers put up and just pushed back and forth. The Scottish Committee have interviewed this surgeon in their committee, I think October 2022, I think they had a long interview in their committee meeting with this surgeon, and he just said it was quite clear that he was being messed about and that he had then decided that it was better the women come to him. In Canada, in Australia, the women tried to get him into Australia. They faced the same steel wall from the surgical community. They wouldn't bring him in. And in Quebec, we have Cynthia Gagne. She had her operation with this surgeon a few months after me, but she started a scheme during COVID where they got groups of women together in a minibus and they shared the driving between Quebec and the surgeon's destination in America. And now 300 women have travelled using Cynthia's service for their operations, including women from Northern Ireland, from the south of Ireland, from the UK, from Europe, from France. Hundreds of patients from France go over to him. And the women go because he gets good results. He gets good results. So we turned down this unique opportunity. And he said to me, Mary, I'll do it because you've asked me. And I think you can maybe bring this across. And when they said no, I took the offer to Scotland. And we worked with the Scottish MSPs. The Scotland cross-party support. And when they got these pushbacks that they wouldn't bring the doctor in, then the Parliament set to do legislation. And there was no opposition at all. This is about our women, the future of our female health. It's about our grandmothers. I have sad stories of women who are in their 70s and have mesh erosion and are in care homes. And the doctors just decide not to do anything. Nobody can imagine the pain of moving with these implants inside them. I lay in bed, bedridden, for weeks on end. The whole summer before the January, I flew to America, and I couldn't move. I couldn't even sit through my Christmas dinner with my children. I couldn't do it. That is the pain. I got relief. I had my implant in 11 years, but there's women who have it in 20, 25 years, and what are they waiting on? I mean, what are we waiting on? If nobody's going to do anything, just be fair and say, sorry, we can't help you. Either find the money yourself or make do with what we have.
One last question. So in terms of the women in Northern Ireland, do we have a recognisable waiting list that we know of women who require mesh implant removal?
Well, we have the Mesh Centre patient list, but women come to me and say they've stopped going to it because they just get sent on urodynamics and physiotherapy. I mean, I've heard tales of this Embrace Your Mesh talk from counselling
Yeah,
and stuff.
so
Give
that-
your mesh a name. I've heard that. I haven't been to these. I'm just reporting back what Women's Day. I was asked to give my mesh a name the way people give stomas a name, and embrace it and realise that, you know, if I welcome it into my body,
It'll be
I'll be
fine.
feeling a lot better. Do you know, I mean,
Yeah.
can you-
I do think that is, Mary, in all fairness, a real example of gaslighting women and the issues, sort of telling them, you know, learn to love it and get on with it, and not acknowledge the pain and the symptoms around it.
Yeah.
Can I say thank you? I think that there are questions there, Chair, that we can reasonably take up with the department. It is not good enough that we put women on a merry-go-round of do this, do that, do the other thing, but we actually don't ever get to the actual nub of the problem, which is that we need to look at how we take foreign bodies out of our body again. So I think that there are important questions that we can ask the department and try and get a sense of urgency around the issue. Can I also say that on the day that we're in, when we've had the Muckamore inquiry and so on, I actually think that the duty of candour in health is more important than ever. Fronting up, telling patients, look, this maybe wasn't a great idea. This hasn't worked for so many patients. We're sorry about that, and learning lessons and being honest about those lessons. And I think there's two issues today that I think the culture and the way that our health service reacts when things go wrong, we need to look at that, and we need to look at it very, very urgently. Can I say thank you? Sorry for going on a bit.
No, I go on a lot myself, as you've seen. But it is. I appreciate the thanks. You know, I know earlier thanked me in the plenary session recently. I appreciate the thanks because I have felt like the boy in the crowd saying there's something wrong with this, and for years people didn't believe me. And it is only through the generous sharing of experiences by the women and the generous sharing of expertise by this American surgeon that I have been able to then read up and ask the right questions and sort of know when the answer is unsatisfactory, if I can put it like that. But, you know, for the women that can pay the amount of money to go, they get their lives back. We're not perfect, but it is as good as it gets. I've been told by doctors the damage that I still have is permanent, and knowing that it is permanent and knowing that I have to befriend the permanency of it, that's fine because I've got a lot of quality of life back.
Yeah.
I'm on minimal amount of tablets, and I don't have those dreaded infections that the women have constantly. Don't have those. I can walk, not great, but I can walk again, you know, reasonably well. I still have pain when I sit, all these things. And, you know, the women that phone me, it's just like we've made no progress. No progress.
Hopefully today will help make some progress. Danny?
Thank you, Chair, and thank you, Mary. I know we've met a few times at various events, and I think some organised by Orlea, and these are horrific situations that women are living through. You'll know that I've had a couple of constituents, but I know one that's been you've been very, very helpful to. So thank you again for that. It strikes me that this is another women's health scandal that we're seeing, and we've seen quite a few of these in the Assembly since we got here, and this time it's as a result of a surgical procedure, so a result of a healthcare that women have got, and they're now having all these problems because of that. I find that absolutely scandalous. I do have a few questions just based on your presentation, and I know we picked on a few of the areas already. The first one, you pointed to the Scottish Government's commissioned arrangement with a particular American surgeon as a model that Northern Ireland should adopt. Has Mesh Ireland received any explanation from the department as to why it has not followed the Scottish approach? And if so, what reasons were given?
The default reason is we have this expertise here. That's a default justification for not doing this.
They're not even considering the Scottish solution. No. Just with that default, now you've said to us, and your presentation has suggested that that skill is not here. You know, you've said that no one in the UK is claiming mesh removal as a super specialism. So I think Diana had asked, does this specialism exist in Northern Ireland? But does it exist in the UK?
The surgeon that I know that started mesh removal is the surgeon that came over to the Belfast Trust and did the training. The start of that was in 2019 or late 2018 when that surgeon started to attempt full removals. The problem is then we had COVID. So we had 2 years where the surgeons weren't doing any of those operations and in the wait list and everything. So this is the UK surgeon that this NHS Scotland has also commissioned, because not every woman can or will or want to fly to America. It's a long journey, and for many reasons people don't wanted the choice. The problem is it took NHS Scotland over 2 years to set this up. Okay, so the other problem is that there's reports from Scotland that the NHS Scotland centre that then commissions the services of the American surgeon, that they are doing a slow waltz in transferring the surgeons. That is the best information I have from reliable sources. So this all setting up of it and commissioning and contracts and insurance and all that type of thing is a very slow process. And as I said, we have an election coming up, then a new committee, and it took 2 years in Scotland to get the first patients out. And I'm just wondering, I'm just wondering, is it not better that perhaps our devolved administration give a letter of comfort to a bank to allow somebody to borrow the money for the surgery, and that the women then go out themselves. It is similar. I mean, I had a meeting at the APG with Minister Nesbitt, and I presented the Scotland model, and a few weeks later he then introduced the scheme where people could pay for their private surgery themselves, which is actually the basis of the Scotland model, that people could pay out with and get reimbursement. But it doesn't work for us because we don't have any reliable data or proof, and the registers set up after the Cumberledge report were 6 years after the Cumberledge report. Nobody is reporting on them. So if somebody asks me, would I go to a doctor that I'm not sure what they're doing to get that removed, my answer is no. So I think patient choice, it's not an awful lot of money. Seeing the Mesh Centre was getting, what was it, £450,000 a year. I mean, that's a lot of surgeries. There was a mesh fund set up for them, recurrent funding. I'm not sure why that money can't be tried out, at least to fund some women to go out. So that's my answer.
And just with that, and I know you talked about the pain, and I've heard from other women about the pain and the discomfort that this has, the idea of travelling, the whole way to America, with that pain and discomfort on a flight that's 7, 8, 9 hours long, and driving with that pain and discomfort when you couldn't even sit through your Christmas dinner. I can't imagine how hard that must have been for the women who have done it, but I'm glad there was relief for them. More women should be able to access that, absolutely. Just with the issue that you're sort of suggesting that there are women who are getting surgeries done by surgeons that are maybe not trained in that specialty and not having a good result. Is there an issue about consent there, about informed consent, that maybe these surgeons were not trained in this super specialism?
Yes. And the get round of that is that the surgeons are getting the women to sign consent forms saying that they will do their best to remove as much as possible, and that the patient is warned that if it all goes wrong, that there's no comeback. So the women are over a barrel, basically. Yeah.
So the consent that they sign
No,
effectively.
Yeah.
Okay.
It is ostensibly correct, but then you need to know. I mean, why can't we have a declaration of at least the hospitals know which surgeons have done which surgeries, whereas the photographs of the mesh that the patients can be given all this documented evidence and not hearsay, or the surgeon saying, yeah, we nearly got it all. You know, that doesn't mean anything to anybody. So how can you consent into an operation that happens inside you? You can't see what people have done. You can't see what state you've been left in. And then the doctor says, well, I did tell you I got you as much as possible. Well, that doctor hasn't been able to remove 26 centimetres of a 28 centimetre mesh and have told the patient I have to leave 2 centimetres in or something. That is one thing. But if that doctor knows that on a good day they still can't get it out, is it fair to consent a woman in and then say, oh, do you know, we're saying as much as possible? As much as possible. If it's a partial removal, just say we're still doing partial removals. Because if you don't remove it all, then you're doing a partial removal, and that's where we started. If people want partial removals, that's up to them, but then you have all the autoimmune problems.
Mary, thank
Yeah,
you.
thank you.
One last question, just for the women who are suffering and waiting on, as Diane said, that waiting list. And I know 20 have went to America and had it fully removed, which is fantastic to hear. You know, that's a good result. For those other women, what supports are available? I know you've been able to support women, but what other supports are available? Is there anything through the trusts or through the department?
Well, the mesh services and their battery of diagnostics and support. Yeah. Mesh groups, I mean, some women are members of 20, 30 mesh groups, you know, and can't sleep at night, and women chat to each other, social media, you know.
Women coming together
women
to
coming
share their
together,
experiences.
GPs don't really know what to do with it, you know, it's usually painkillers and more painkillers. No, there's not a lot for them, no.
That's terrific. Thank you very much.
Thank you.
Oh.
Thank you, Chair, and thank you, Mary, for your information. I think it's really clear that you've come to this with a problem. You've also come to this with a solution in some places, and that comes with an ask. And if we reflect back on the number of years, and I think you've detailed all of the information really that's there. There's not many questions left other than a comment, and the comment I have is that in terms of this and other issues, I really thank you for giving us the word hope mongering. Because I think that's what this executive does on a weekly basis, on a raft of issues. Because we get all party support in here for the issue. Then it goes out that door and we don't see any progress. And you've been, 10, 15 years working on this? And the issue's so detailed. And we look at places like Scotland and you go over to there and the problem is presented. And then they follow up the solution and it's sorted.
Yeah.
And places in America, they're getting solutions. Go to Australia, they're getting solutions. Go to England, they have the report, although the redress hasn't come to it. Can you give us a sense, and maybe this might land with some of the ministers, about the level of frustration that there is amongst those that are suffering, that are campaigning, but are not seeing any action whatsoever into trying to address the issues that you have?
We feel as if it's a form of institutional abuse to do inquiries and put up recommendations, and for successive governments, regardless of which political leaning they are, to criticise the other side, and then when they get into power to say we're not doing anything. For the women, I mean, they're frustrated. The women that use their savings, they're frustrated that they're not getting reimbursed because they're in, you know, alleviating the health services by not. I haven't been back to the hospital since then. The other thing is, you know, this delay in time. Claim for medical negligence is three years since knowledge of the event. Okay, I mean, a lot of women had no idea what was going on with them, have missed that boat. And then there's 10 years for medical implants. In Northern Ireland, we don't have no win, no fee. So these types of litigation, again, it's outpriced, and women can't try to get some redress through that. And the medical negligence claims can also take up to a decade to run. So there's no financial redress there. A lot of women don't get PIP. They get PIP on something else, but not on their mesh injury, and we have worked together with PIP. There's no sign that there's any money coming. The women are getting older. They're afraid their pensions are gone. So, I mean, on a good day, the women are very frustrated. On a bad day, they're really, really angry with everybody. And you know, when I say I'm going to talk to them and say, "Oh, it's just selfies on the steps of Parliament," and they say they're going to do something, and you know, and you go on the radio and you talk and everything, and then nothing happens. So you know, I can't deny that is the case, even with all the goodwill I have around me.
And the difficulty is, I mean, we've a minister that is, you know, self-detailed that he's going to stand down at the next election. You know, that's only 7-8 months of work away. The chances of anything happening in that period of time are slim. In fact, they're probably non-existent, which means that we're looking into the next mandate, and as you've detailed the length of time that will take. And Lord knows how many rows and arguments there'll be before this even lands onto a bit of paper in front of a minister. So that sheer frustration is really palpable. But I just hope that it can land with whoever is the next minister, and that is something that will become a priority for them. But we don't often get much action, and that's really, really sad whenever we hear in such a visceral way from you exactly the issues that people are having to face when it's about pain, when it's not about not being able to walk or not being able to move, not being able to enjoy life. And yet, as I said at the start, you detail the problem, but you've got a solution and you've got an ask. So I just hope that some of that can land somewhere.
And can the committee not take legislation and rush it through before the mandate?
Even get the legislation that we have through probably in this mandate, which is the sad bit. And again, it's that hope mongering that, you know, come in, present to a committee and sure it'll all be sorted. You know, it is deeply, deeply frustrating that the systems are in place that they don't bring resolutions to people whenever you need them for your day and daily life.
Yeah, the women, you know, they've noticed the activity around endometriosis and everything, and they feel like they've been shelved now, and that the MLAs are moving on to a new story, you know, nothing more to be said about mesh. And you know, it's not a jealousy, but they just think, yeah, we were told we were going to get pathways, we were told we were going to get all of this, and all these years later. I'm just mentioning it, you know, as an awareness of how cynical patients who are abandoned can feel towards the delivery of our parliamentary institutions.
Thank you, Deputy Chair.
Alan?
Thanks, Chair. Mary, you're a very powerful advocate. Applaud you for that. Some of the areas that I wanted to explore have been covered, but I think there's a few of them that I think are still outstanding. So, for those women who can avail of this surgery privately, what kind of figure are you talking about?
I don't know. To be honest,
but many thousands, 20, 30.
Well, I mean, I think that on the slides, I think Northern Ireland doesn't have good records of how many of anything in terms of the health services. So they sort of did some type of projection, and they said in the second decade of mesh implantation, it was round about 10,000 women that were implanted. And I think they took a 3 or 4% injury. I've heard 10% injury rate. I've heard 15% injury rate. So those are figures. Those are figures that nobody knows. I have just under 400 women on my Facebook group, and I only allow women from the north of the south of Ireland and who are genuinely. I don't take people in from all over the UK and the world. I just couldn't cope with that. So I don't know. That's my honest answer. But even if the figure is low, I mean, if you knew it was only 40 or 50 women who wanted these operations, that makes the bill a lot more palatable, and could be tried as a pilot to see how these people fare. There's often this thing about aftercare, but You know, when you come back home, your doctors, your specialists, not super specialists, they can deal with aftercare. And I haven't been back to the hospitals for this issue since I returned.
Mary, just in case I'm misunderstanding this, for those who can afford to avail of private surgery from this American surgeon, you're not aware of the cost for someone here?
Oh, sorry, I misunderstood the cost. Okay, it's between 18 and 22,000 pounds. Yeah. And that it always depends. Some women have more complications and different types of meshes. You've seen these big surface meshes. On average, a woman with a tape pays between 18 and 22,000. That is for everything in the hospital and a hospital stay of a day. You're discharged the next morning. I was able to walk perfectly well and stayed in a hotel, and you can fly back after 10 days. And you have your full care with the surgeon. Until you leave, and you have to stay 10 days in America before you can get on a plane to come home. So that's
benefits to Northern Ireland PLC.
Yeah. In
terms of that 18 to 22,000 pound.
Yeah.
In the long term.
Yeah.
Is a huge saving.
Huge. And the other thing is then for people who can't travel or want to use services, the wait list for our local surgeons goes down. Sorry, I misunderstood your initial
question. That's okay. So in terms of these super surgeons,
how
many are you aware of across the world who can carry out this specialism?
I'm aware there are other American surgeons, but some of them cut muscle, which is another technicality. Dr. Veronica's, he doesn't cut muscle, so my groins had to be opened to get the mesh out of my upper thigh. And the problem is that some surgeons go in with a plastic surgeon, and the surgeon cuts the muscle to pull the tape out, and then the plastic surgeon tries to reconnect the muscle. And if that goes wrong, you lose a lot of the power in your inner adductor muscles. Anybody who does sport knows the role of the thigh, the upper thigh muscles. So there are other surgeons that do that. I've noted in the UK medical journals that they've stopped using the word muscle sparing in their publications, and they do go in with a plastic surgeon. So it depends what risk you're going to take. This surgeon that I went to, he does this day in, day out. He takes out in a week what Northern Ireland hasn't taken out in 5 years.
In terms of the commissioning service
that
is available in Scotland, are there plans to do similar in England and Wales? Are you aware of?
No.
Why?
No, because they're going to rely on their surgeons. They're just not sending the women out. They're just not sending them out. The English people go elsewhere as well. There's big long waiting lists in the UK as well, because it's not a life-saving surgery, so it's just an elective surgery. And again, Scotland also commissioned the UK surgeon I mentioned, so the women had the choice. So I think the women have to have the choice, and it's their lives, it's the rest of their lives they're talking about. Why shouldn't they be able to fly abroad? It's not surgical tourism like going to get lip filler somewhere or something. You know, this is serious medical damage. Yeah.
Do you see, Mary, like in a very simple ideal word, a model similar to the waiting list initiative, whereby there is a pot of money set aside for people to apply to that can avail of this specialist service?
Yes.
And that would be the ideal model for here, for Northern Ireland.
Yes, and that they can choose which surgeon they want to go to within reason, UK or America. Yeah?
And that pot of money that would be made available overall would save the health service here many times over and above that.
Absolutely, and also the other ancillary welfare networks, nursing, care, all that type of stuff people have, nurses having to come into homes and stuff. Absolutely.
Thanks, Mary.
Yeah.
And it would also prevent a lot of suffering and end a lot of suffering for these women who are living with those conditions.
And also family breakup. I mean, I have occasionally had, I remember a very poignant call where a lady phoned me and said she was down in the sea yesterday and just thought of her children and came back out of the sea. You know, I mean, this is how serious this suffering is. Yeah.
Horrific. And can I just add, as a quick question, just on top of Alan's, when Alan was saying there about the price that women have paid, you said £18,000 to £22,000.
Yeah.
And the women from Scotland who have paid that, they can reclaim that, is that correct?
The women who had gone abroad before the introduction of the legislation could reclaim it with the provision of paperwork, etc. And then there was a cut-off date, and from that point on they had to go through NHS Glasgow, I think was the referral centre, and NHS Glasgow worked with the American surgeon and did conference calls and sent the people over. But I mean, you know, Scotland paid for their flights, and a lot of them flew that were very damaged, flew in, you know, not economy class flights, depending on the seriousness of their situation. You know, it is doable in economy flights. Of course you're in pain, but you just think you've hope. you have real hope that it's worth the pain, and you know you're going to be anaesthetised for 2 days later. So it's desperation. You just think, I have to do it. I have to do it. I remember struggling to walk through Heathrow and struggling the whole thing, and we just we flew in the cheapest flights to get to the Midwest of America in January, and there was there's ice, wind and everything, and we just bunkered in, had our surgery, stayed in our hotel room and flew home, and it worked, and it was the best decision of my life.
Glad to hear that. Alan?
Thanks very much, Deputy Chair. This health committee, I find it tends to be a school day every time I come, and certainly today has been yet another school day. And it is something that I'm aware of, it's something that I've read about in the press, but it's only when you hear somebody sitting at the top table and telling us about their personal experience that you suddenly realise this is for real. It's not just something that journalists are writing about. But in terms of the cost and the availability in America, what's the sort of, you decide you're going to go to America to get this operation with this particular surgeon, how quickly can you set that up? Now I'm sure there's a process which I'll ask you about, but from you decide that I'm going to go and get this done, what would be the waiting time?
Dr. Veronicus, the surgeon, he prioritises the patients according to need. He has a surgical rota, so he operates 5 days a week and does 2 to 3 surgeries, unless it's one of those really big 8.5-hour surgeries a day. And to give an example, there was a story on BBC Northern Ireland a while back from the lady in the Northwest who flew over. She phoned me, and within 10 days she was in America getting her operation. So if somebody has mesh in the bladder or something, he will prioritise that, because obviously the risk of damage is, if somebody is very distressed, he will try and prioritise that. So he plans 2 months in advance. He has a lot of overseas patients, so when people book flights and things, there's not as much wriggle room, but he has local patients, so he can act very quickly.
Yeah, but it could take a couple of months, and that would be understandable.
Maybe 4 to 8 weeks. But as I said, I've had people who were emergencies, and they have got the money together, and he slotted them in.
Would there ever be a case where he might? I presume you'd want to see all your medical records and stuff before you would make a decision if he can help you. But would there ever be a case where he might reject a patient that he would feel maybe if they had other heart complaints or something that would make surgery even super difficult, that he might feel that it wouldn't be in the patient's best interest for maybe him to operate on them?
That's a very valid question. He has a video conference with the women and their family if they want before any decisions are made. And he asks them to send their medical records. He doesn't want any of these diagnostic records. He just wants their surgical notes, so he can understand what happened in any surgery that they've had, what the surgeon has done. He likes to see the surgeon's drawings and things, so he can envisage in his mind what he expects to find. There's been women gone out that have had heart conditions. He's told them to go to cardiologist here and get the things that he's very. They also it's a very established medical centre in America. Obviously they have specialists there, but to avoid women having extra costs and everything. Sometimes people have had so many removals that he is not hopeful that he can do anything, and those are individual conversations he has. So if you haven't had your mesh touched and it's still in you, that's for him the ideal situation. If it's been cut already, he likes to see all the surgical notes. And then there's people with fistulas and cysts and all this type of stuff and other urogynecological matters. Each woman is unique because these surgeries, as has been pointed out, are a part of their gynecological history. Some women, talk to me, and then I said, "Have you had anything else?" And I said, "Oh yes, I had my womb removed." Oh yes, there was this. I had a car accident. So everybody is individual, and those are conversations where I step back and say, get in touch. There's the details. Talk to the surgeon, and your family can sit in and they can ask questions. He's very patient because he knows it's a big decision for people to travel over. That is the decision you make. But the women who've been out before, they support women who are thinking of going out. So there's a network there that people phone each other and talk them through. But it is a big decision. But if you're going to the world expert, the risk is better managed.
He certainly he sounds like a good man, a very genuine man. You hear about, people hear packages, and there's agents selling packages to go to Turkey for plastic surgery, to get teeth done. And it's all a package. They'll put you in a hotel for a couple of days and then send you home, and all sort of problems can arise. But that fee that you've quoted there, it's not a package, that's just his, that would just be the surgical.
That's the surgery and the hospital fees for the 24-hour stay.
What about, there would be add-ons, what about, I struggled to get travel insurance just to go to Spain for a week.
Yes.
And I always feel that I'm getting ripped off by what they charge me. Is travel insurance a problem? Because if you're going there to get surgery, that's the first thing these people ask you.
Yes.
The insurance companies, you're obviously high risk that something might go wrong, and they're going to end up with a huge bill to try and get you home and so forth. So do the women find travel insurance a problem?
You can only get travel insurance for normal travel insurance if you're hit by a bus. They don't cover. People have bought a medical insurance, but they find it's extremely expensive. Yeah. And it has so many caveats that they wonder if it's worth the risk. And so that is a risk we take going out there. Obviously, when Scotland send their patients over on the NHS then are responsible. They're responsible, and that is a great comfort to the patients. Having said that, my experience of the services that I experienced in America, I have every confidence that in the exceptional cases somebody has complications, that they would be looked after.
Yeah. The other thing, the reality is that we talk about 20 grand for the hospital. There's a lot of add-ons, and that adds to the burden of a woman that was wanting to self-finance to go. You've got you certainly wouldn't want to travel alone, or maybe you could travel alone, but I would imagine, given a recovery period and all, you'd want a companion with you. So, and you say that you have to stay in maybe a hotel for a week after to make sure your recovery's fine, or maybe even 10 days. So you've got, that's an added on, and then you've got the international travel and then internal travel as well, which is not cheap. So it really is a big financial burden on anybody wanting to go. And
it is.
It's obviously if the state did provide, it would be making an awful lot easier for folk.
It would, and even if the surgery costs were paid, the hotel. I travelled out with another mesh injured woman. and we lay in a hotel in the town with a double room, and we sat and watched TV, and we weren't that hungry after surgery. Do you know, I mean, the hospital's wonderful. It's like a 5-star hotel service. But you know, you'd eat at home, so you know the food bills weren't massive. We were recovering. We had catheters on for 5 days, so we weren't exactly going out. And it's not a sightseeing holiday. You know. Yes, isn't it wonderful if you could all travel first class? But you know, as I said, if you've been in pain for so many years, you suck it up. A lot of people suck up a lot of pain on a day-to-day basis, and we
put a price on getting that pain taken
away.
Yeah,
and it was that realistic hope that you know. Obviously, if NHS are sending you out, they probably wouldn't send you on the first day the air prices dropped to America in the middle of January, you know, and you wouldn't be sitting in a 5-row seat for 13 hours and just in pain.
We're very grateful for your presentation today. Thank you.
Thank you.
Thank you, Mary.
Yes, thank you, Deputy Chair.
Linda, you had briefly your hand up. Are you happy enough?
No, it's okay, Chair. It's been addressed. Thank you.
No problem. Mary, thank you very much for your presentation. We got a lot of information there, and there will be aspects of this that the committee will be following up. So thank you very much for that today, and your work you do for those women. Thank you.
Thank the committee, all the politicians. I know you're all good people working hard. I really do. And I wish to thank all the women who have trusted me to represent them as well. I'm sorry if I sometimes speak a little too long, perhaps, on things, but this is our first opportunity in all this time to put the MESH story of our women on public record, and for that we are all very grateful. So thanks very much.
Thank you.
Thank you.
Thank you.
Okay, members, we had quite a lot from that, but I'm going to ask first, does anybody any other comments? Nope. I'm just going to go through this. So if members would agree, we could ask the Department of Health for further information about the number of women harmed by this issue, for an update on the action taken to support the women affected, to detail the availability of mesh removal surgery, including the waiting times, and to ask what consideration has been given to establishing a reimbursement scheme similar to the one provided in Scotland, and for what engagements have been taking place between the Department of Health and Social Care in relation to a financial redress scheme. Is everybody happy with those?
We'll just be a wee bit more specific around the stats for full removals of the mesh. Because Mary had mentioned that in that FOI request about some of the hospitals over in England, they were saying that they had done 2 in that 5-year period. So I think as much as we can drill down into that type of detail with our department, and maybe even posing the specific question around in response to, do we hold that super specialism of complex mesh removal?
Yep. I was going to add, and I think that's absolutely right, that we have as much detail on that as possible. I know you had raised during your contributions just asking for clarity about the availability of mesh removal expertise.
Mm-hmm.
That's happy enough for that?
Yeah, just on that super specialism stuff, I think that's important, because I've got lost in all this detail in a million assembly written questions that I put in. I still get lost when the responses come back, so the more specific we are, I think the better. And if we could also, you might have mentioned it, Chair, there around the Scottish model, we did write off, and I have wrote off the ministers, Mike Nesbitt, probably Robin Swan before that, but around consideration of the Scottish model, and also they are aware of the doctor in America who we've spoke about. I actually met with the surgeons from the Belfast Mesh Clinic a number of years ago, and on this very topic around the skills and expertise of this doctor in America. So if we can just get that in the letter too, to see if there's if that conversation is dead in the water.
We had a few other questions. I'm just going to read them out, and then if anybody wants to add anything. No, you're grand, Orlia. So Linda had asked for a timeline on the Women's Health Action Plan, and if that was part of it. Linda had also asked for engagement with Mesh Ireland on the Women's Health Action Plan. Diane had asked about the availability of data, re the Mesh surgeries. I think that's similar to yourself. And consideration of the international expertise in mesh removal surgery. So
can I be specific about that,
Yeah.
Chair? So what I really wanted to know was there any consideration by the department to bring in that international expertise rather than women going over to the States or wherever they need to go, but are they considering bringing those people here? And I think we should just ask the brutal question, is there a super specialism on mesh removal in Northern Ireland?
Yes.
Just as simple as that, where you can say yes or no. Now they'll probably not say yes or no, they'll have a whole
What about,
palaver
and
around
if
it.
not, have you any plans to
And if not,
deploy
have you
one?
any plans to bring that in? I think that is the nub of the issue, because I think the nub of Mary's thoughts were that we need this, we don't have it in Northern Ireland, and everything else is just partial and probably in the long run providing more problems than it is solving. I think it is very worrying though when you hear stories of women being so gaslighted by the health service. I think that's very worrying.
absolutely agree, and I think the idea of women who are living with such discomfort having to fly to America, it's horrific.
But also being told, like, you know, name it, love it, pretend it's what?
Nonsense.
Anybody else, any other questions that they want to ask? Or,
Sure.
Sorry, Linda, you had your hand up there.
Yeah, sorry, just I know Orlia had asked that question about the super specialism. Can we ask if they're saying that they have it, how many surgeries have they carried out, and if we can find out some outcomes of those surgeries, that would be helpful, because that gives us a bit more detail on, you know, pushing them into that the specifics around it. I think that's really important. I mean, on Diane's point about it's worrying, it may be surprising, it's not. This is happening in every sphere of women's health. So, like, you know, there's no point in us kidding ourselves any longer. This is a consistent theme through every single aspect of women's health. And just on the Women's Health Action Plan timeline, which is grand, it's not, you know, looking for them to have engagement. They've actually apparently completed their consultation period on that. We're waiting to know what the timeline is on bringing it forward to us, you know, on delivery. So it's, did they engage the women, the mesh injured women, as part of that consultation process? So that it's a specific question on were the mesh injured women engaged as part of the specific process, the specific consultation for the health action plan?
In terms
Thank
of,
you very much, Chair.
No, you're grand, Linda. In terms of outcomes, I take it you're referring to full removal and
Full removal.
Yeah.
Full.
Not
If
partial.
there's super specialism, I think have they succeeded in full removal
Thank you.
where that was their intention? Because of, I mean, if Mary's point's right, and they're doing partial removals, but they're telling the women we're going in to do full removal, and then telling them afterwards we got 2 centimeters of a 30 centimeter mesh. I think we need to try and be as specific as we can on these questions, because Orly is right. She's been asking about this for as long as I can ever remember. I think she said 9 years, and has been constantly campaigning in relation to this issue, but has been fobbed off time and time again by officials and by the health service itself.
Thank you, Linda. Nuala?
Thank you, Deputy Chair. Look, I just I didn't ask any questions to Mary there because she did cover some of what we were going to ask. And I wondered if we could actually contain within that, because you know, I listened to the answers that I believe it was earlier in oral questions, you know, ask this as an oral question every now and then. And the answer that we get from the minister and the past few of them has been about awaiting the outcome of what is happening across the water in terms of compensation redress, but also medical next steps. And I actually wonder if there has been any communication with counterparts in England and Wales or Scotland for actually working together on what's the best way forward if this is such a niche specialty area. So if we can include that within the correspondence, because you know I wouldn't doubt that there'd be very little.
Thank you, Nuala. Is everybody in agreement then? We can go on ahead with those questions. Thank you. Okay, folks, moving on to our next item. We're going to take correspondence at this stage of the meeting because we have a legal advice coming up next. So I'm just going to refer members to correspondence in your main pack from page 97, including the correspondence index at page 99. So first I'm going to refer you to a response from the department at tab 10.8, page 118, in relation to the committee's request for an assessment of funding shortfall for the cancer strategy, the use of abiraterone for the treatment of prostate cancer, and any progression of work in relation to the detection and treatment of ovarian cancer. Does any members have any comments on this? Nope. Okay. I'm going to refer members to correspondence from the department, page 118, providing a response to our request for information about the impact of shortfall of funding for the cancer strategy. Any comments from anyone? Not seen anything. I'm going to refer members to correspondence from the BMA at tab 10.28, page 230, regarding the announcement of the result of a vote on industrial action from SAS doctors, specialist, associate, specialist and speciality. Do members have any comments on that? Nope. Okay, are members content with the suggested actions in the correspondence index at page 99? Yep. Okay, we'll move on then. So our next item is legal advice on the Adult Protection Bill. So I need to seek members' agreement to move into closed session for the next briefing from Assembly Legal Services on the Adult Protection Bill. Members content to go into closed?
Yes.
Yep.
Committee Room 29. Sound. 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 Committee Room 29, 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 Sound. Committee